Hi, and welcome to the 2022 Focus on Pulmonary Hypertension Research Live, presented by the Pulmonary Hypertension Association. We're so happy that you are here to join us and learn more about the clinical advances in pulmonary hypertension research from our team of experts. Before I introduce our team today, I would like to thank Janssen Pharmaceuticals for their diamond level support of PHA Connects 2022. That support helps to fund educational programming such as this one. For our speakers today, we have a great panel. Our first speaker will be Dr. Corey Ventitulo, who is an Associate Professor of Medicine and Associate Chief of Pulmonary Critical Care and Sleep at Brown University. Next, we have Dr. Thenapin, who is also a clinical researcher focused on translational research in pulmonary vascular disease from the University of Minnesota. And leading this discussion today, we will have Dr. Anna Hemnes, who is a researcher in pulmonary vascular disease and treats patients at the Vanderbilt Center for Pulmonary Vascular Disease in Nashville, Tennessee. And joining her will be her colleague, Dr. Evan Brittain, who is an associate professor of medicine in the Vanderbilt University Medical Center Cardiovascular Division. Dr. Brittain will start off our conversation. So Dr. Brittain, welcome, and I'll let you take it away.
So thank you, Angela, and thank you to the PHA for organizing this, for the invitation to be a part of this live event. I'll speak for the co-panelists that we're all excited to be a part of this, and we're thrilled that so many of you were able to make it. Anna and I will introduce our speakers, and we'll also field some questions. We're also aware that several questions were submitted prior to the beginning of the event, and we'll do our best to address as much of that content as we can. So I had the privilege of helping to organize the 2022 PHA scientific sessions, and among the most attended by both medical providers and patients and caregivers were the talks about treatments and treatment advances and research around potentially new treatments. And so we thought that we would focus here on some of those treatments that span the spectrum of all the PH groups. So I'll start with introducing my close friend, Corey Ventitulo, who wears many research and academic and leadership hats at Brown University. Among the most relevant, she's Associate Director of the Pulmonary Hypertension Program at Brown, and we'll be speaking today on particularly some clinical trial advances in Group 1 PAH. Thank you, Corey, for being with us.
Thank you. Thank you, Dr. Brittain and Hemnes, as well as the PHA, for the invitation to speak today. And thank you to all of you for joining. I'm going to just share my slides here. All right. Can you all see this? Yes. Okay, great. So I'm going to start just with my disclosures. Relevant to today's presentation are I've served on past advisory boards for Acceleron Pharma and Merck, Altivan Sciences, and I am the PI and study co-chair for some NHLBI funded clinical trials that I'll be discussing briefly today, as well as on DSMBs for investigational therapies not being discussed today. So I'm going to start with a little bit of an overview of where I think we're headed, or where we've been for a few years now, and that is in terms of combining therapies for pulmonary arterial hypertension in upfront combination therapy. I should say here that the specific trials I'm going to focus on in this talk really have occurred in the past year or two. So if I've left out a trial that you're interested in, you can feel free to bring that up in the question period. But why are we talking about this as a field? And as we are all well too aware, despite improvements in PAH treatments and prognosis, we really still have work to do in terms of improving long-term outcomes for our patients. And there's been compelling prior research, including from large randomized clinical trials, which we consider the gold standard in human subjects-based research, that suggests the benefit of combination therapy in our patients. So I'm going to review two combination therapies that have been completed in the past year or two. The first is the REPLACE trial. So REPLACE focused on asking the question, in patients who have been stable or potentially had an inadequate treatment response on phosphodiesterase type 5 inhibitors such as sildenafil and tadalafil, should those patients, or will they benefit from a switch to riociguat? Since in essence, both of these therapies or all of these therapies target the nitric oxide therapy. So this is the main outcome from this open label trial that was conducted. And you can see here on the left bar is individuals who were randomized to riociguat versus those randomized to PDE5 inhibitor. And pink is what we want. Pink is that these patients or these subjects in this clinical trial achieved the desired endpoint. And so more subjects did that in those randomized to riociguat versus those randomized to PDE5 inhibitors. And if you focus here up top, only one subject had clinical worsening in the riociguat arm versus 10 or 9% of patients in the PDE5 arm, including 3 deaths in that group. And so this seems to be pretty convincing. However, it's important to point out here that one of the issues with the replace trial design, in that it was more of a pragmatic approach, was that this trial was not blinded. So both investigators and patients who were participating in the trial knew what they were getting. And some of the endpoints, many of the major endpoints that drove that primary endpoint I referred to on the last slide, could be subject to subjectivity. So, for example, here on the left is change in 6-minute walk distance, and you can see here that riociguat randomized subjects did better than those on PDE5 inhibitors, as well as improvements in functional class in riociguat and versus the PDE5 inhibitors. This is compared to a more objective endpoint, if you will, a readout in the blood called N-terminal proBNP, which is a marker of heart stretch. And you can see here there was really no differences across this more objective marker. And so I would say the conclusion from this trial is that it may not be unreasonable in patients who have had unsatisfactory clinical responses on PDE5 inhibitors to try to change them to riociguat, but acknowledging sort of certain limitations of this trial. I'm going to go next to the Triton trial. This is a multi-center, double-blind, randomized, placebo-controlled phase 3B study, which asked the question, is it better to start patients on 2 versus 3 oral combination therapies in pulmonary arterial hypertension? So roughly 120 subjects were randomized to macitentan, tadalafil, and selexipag, so one therapy from each major drug classes versus macitentan and tadalafil alone versus just a placebo. The primary endpoint in this randomized clinical trial was change in pulmonary vascular resistance, and you can see here if you got upfront triple combination therapy versus double combination therapy, really it did not impact the amount of resistance in the pulmonary circulation. And then other secondary endpoints like the 6-minute walk distance and the NT-proBNP that I referenced a minute ago also demonstrated no difference. What was interesting, however, is that in this study, there was a secondary endpoint analyzed in an exploratory fashion to look at what was the time to the first disease progression event, so anything like death or transplant, hospitalizations. And you can see here that individuals who had triple oral versus double oral combination therapy did better. And when you unpack that first disease progression event, this was driven mostly by a difference in hospitalizations. So patients who were randomized to receive 3 versus 2 therapies had lower rates of hospitalizations, and there was also a lower rate of death. However, because this wasn't the primary endpoint or the primary objective of the clinical trial, on balance, this would be considered a negative study, but with some signs that perhaps initial triple combination therapy may be beneficial in select individuals. So what are my thoughts on upfront triple combination therapy? I think this remains a really controversial topic in the field, and something that we need to do better in terms of studying which patients work for which therapies will work the best for which patients. I think we also need to consider quality of life and side effects, as well as the burden of adding more treatments to patients' regimens. And as I mentioned a minute ago, we really need to do more to study individualized treatment responses in PAH so that we learn more about selecting the right medication for the right patient. and limiting medications that conversely don't help but add to side effects. So I want to move on now to a topic that's favorite for me. So this, some may have heard of what's been labeled the sex hormone paradox in PAH, and that is that women are more likely to get pulmonary arterial hypertension. So about 70 to 80% of patients with PAH are women, and yet we know now that women with PAH are more likely to survive. And so we've spent a long time studying what might explain these differences. And some years ago now, we and others identified a circulating hormone signature in the blood, which demonstrated an increased risk of the development of PAH as compared to healthy matched controls, as well as a signature that, when abnormal, tracked with disease severity in pulmonary arterial hypertension. So we've now shown this, that in both pre- and post-menopausal women, as well as men with PAH, there are higher circulating levels of estradiol, which is similar to estrogen, and lower circulating levels of dehydroepiandrosterone, which is the fountain of youth hormone in these groups. And as I mentioned, these levels also correlate with disease severity in PAH. So we are going on now to study this in randomized clinical trials. And so I'm conducting the EDIFY study. This is the effects of DHEA in pulmonary hypertension. We are aiming to enroll 26 individuals with group 1 PAH. We have currently enrolled 23 individuals. And we'll be looking not just at the traditional endpoints like 6-minute walk distance, but really primarily at right heart function in response to giving back the supplement DHEA. And we're hoping to complete this trial and have results within the next year or so. Second, as I mentioned a moment ago, we wanted to also try to manipulate this abnormal estrogen that seems to be circulating the blood of both men and women with PAH. And so some years ago now, my friend and colleague Steve Kaywood spearheaded this small pilot study of using an approved breast cancer drug, anastrozole, to reduce circulating estrogen levels in the blood. And you can see here up on the left that we gave a very small number of PAH patients anastrozole versus placebo, and those that received anastrozole successfully reduced their circulating estradiol levels without a change in their right heart function, but actually an improvement in 6-minute walk distance as compared to placebo control, the controls who received placebo. And so there are now 2 ongoing trials that are targeting estrogen specifically in PAH. On the first here on the left is the PHANTOM study. We and others were a part of this multi-center phase 2 randomized clinical trial. It was a huge effort, and I'm proud to say that we've completed the study and results will be forthcoming shortly. The second is the T3-PAH study, which is ongoing at Dr. Brittain and Hemnes Center in Vanderbilt, run by Dr. Austin, and he is using tamoxifen as the investigational drug. And I think he's on a similar pace to the EDIFY study as me. So hopefully soon we will have answers to these pressing questions in terms of the sex hormone paradox and using hormonal modulation as a treatment strategy. The last thing I want to turn to is BMP signaling. As many are probably aware, BMP is one of the causal pathways, downregulation of BMP signaling is one of the causal pathways in PAH. And so based on really beautiful preclinical data, the drug sotatercept has been developed. Conceptually, this is in an effort to rebalance BMP signaling in PAH. So sotatercept works to bind up these pro-proliferative molecules, activins and GDFs, and sort of turn off this feed-forward loop to promote anti-proliferative signaling in pulmonary arterial hypertension. PULSAR was the first phase 2 trial of sotatercept in PAH, which was published a year ago now in the New England Journal of Medicine. Patients with pulmonary arterial hypertension were randomized to placebo or 1 of 2 doses of sotatercept. You can see here on the left that the primary endpoint, which is a change in pulmonary vascular resistance, was met. And in fact, there was quite a large reduction in pulmonary vascular resistance from baseline in individuals receiving the 0.7 milligrams per kilogram dose. They also succeeded in improving 6-minute walk distance at week 24 as compared to the placebo group and reducing circulating levels of NT-proBNP. And several weeks ago now, Merck announced that there were positive top-line results from the pivotal phase 3 STELLAR trial, which looked at sotatercept for the treatments of adults in PAH. And they were successful in hitting many of their outcomes, including 8 of 9 of their secondary efficacy outcome measures and their primary endpoint, which is the improvement in 6-minute walk distance. So we anticipate drug approval, I believe, in the next year, although the data has not yet been published on STELLAR. So there are a number of ongoing trials and emerging therapies in PAH. The last time I checked on clinicaltrials.gov, which is the central repository for clinical trials, there were over 250 active trials ongoing. So I think it's a really exciting time. I've listed just a couple of the things that came up here. Dr. Thenepin is passionate about microbiota transplant, and I think it's a cool idea as well, although I'm not sure if he's going to be discussing that today. And finally, I just want to wrap up by saying this is a really exciting time in PAH. I think as a clinician, physician that takes care of patients, but also as a researcher, and for patients as well, we're finally looking at agents which might directly target the causal pathway in disease. We're thinking very carefully about the right medication for the right patient. We have the challenge about studying new therapies on background and combination treatments, but I would say that this is a really high risk, high reward period for PAH. And I just want to end by saying I owe everything that we do to patients who willingly participate in these clinical trials. We ask a lot of you as well as caregivers and families, so thank you. And of course to the research staff who help to make everything run smoothly when we're conducting these studies. Thank you.
Thanks, Corey. That was a really great presentation and really informative. I think as they're getting the slides switched around, Evan and I have a few questions for you. You want to ask your question, Evan?
Yeah, I'll start with an easy one that you may welcome. So someone asked about how they might be involved in your clinical trial, which I think was a DHEA trial. You want to give us some info on that?
Yes, I'm happy to put my email and also my coordinator's email in the chat. We are definitely interested in chatting, and we're happy to share information.
Thanks. I had one question that I think is probably pressing for a lot of people listening in on this webinar, and that's sort of reading the tea leaves in the future. How do you envision using sotatercept, assuming it gets FDA approval?
Oh.
Not an easy question.
Harder than Evan's question.
Right?
Yeah, I think we're going to have to do a lot of work to figure out, as I said, which patients and when, and do we start to think about doing sotatercept before we do what has long been gold standard, parenteral prostacyclins? So, in patients who are on oral therapy and not doing well. In my mind, I think it has to all start with a conversation with the patient about what they want, what their goals are, and what for them is important in terms of quality of life. So, I think we're once we see the data and provided it's compelling, I think we have to have really educated and nuanced discussions with our patients and their caregivers about where the gaps in data still are. So certainly we haven't, tested sotatercept or any therapy up against the gold standard, but sotatercept does look to be effective against patients that are on significant background therapies. So how can we get more precise in individualized treatment programs?
Thank you. I think that's exactly what I'm thinking too in my practice. I think with that, we'll switch over to our next presentation, who is Dr. Evan Brittain, who's at the University of Minnesota, also a long-term friend of ours, he presently is the Associate Professor of Medicine in the Cardiovascular Division, and also is a section leader for the Pulmonary Hypertension program there. And so we're feeling very honored to have him here today presenting on new therapies in non-group 1 pulmonary hypertension. So with that, I'll let you take over.
Evan, I think you're muted.
Perfect. Can you hear me now? Great. Okay. Thank you, Dr. Hemnes and Dr. Brittain, for the opportunity. It's always a pleasure to do the patient-oriented webinar. It's very gratifying and satisfaction. So I think in the next 15 minutes, I will cover the recent updates or recent therapies that's been evaluated for the other types of pulmonary hypertension. Dr. Brittain gave a beautiful overview of what's happening in pulmonary arterial hypertension, which is group 1, but there is pulmonary hypertension due to left heart disease, pulmonary hypertension due to lung disease, and also pulmonary hypertension due to blood clots, otherwise called as chronic thromboembolic pulmonary hypertension. And as you know, there are many therapies that's approved for treating pulmonary arterial hypertension, and some or one drug so far approved to treat the chronic thromboembolic pulmonary hypertension. So there's really no therapies for patients with pulmonary hypertension due to left heart disease or lung disease. So it's really a large unmet need. And I'm glad that there is some recent progress in the last few years, and I'll share those. First, I'll focus on, these are my disclosures. I served on the advisory board for Actelion, United Therapeutics, Alpine Science, and ARIA CV. I also, my institution receives research funding for clinical trials from United Therapeutics, ARIA, Gossamer, and Acceleron. First, I'll discuss the INCREASE trial, which is a randomized double-blind placebo-controlled trial that was conducted, were published last year. And this is the trial that looked at inhaled treprostinil in patients with pulmonary hypertension due to interstitial lung disease. So this is a large randomized controlled trial. We call it as a phase 3. It's a placebo-controlled trial. There were approximately 240 patients, actually close to 300 patients, but at the end, 240 patients completed the trial. So 120 patients were treated with placebo, which you can see in the gray line, and 120 patients were treated with this inhaled treprostinil. Inhaled treprostinil is otherwise called Tyvaso. This is a drug that's already approved to treat the group 1 PAH that's now being tested in patients with lung disease. And the investigators chose this drug over other oral therapies or IV therapies because in lung disease, what we know is like if the drug goes systemically, meaning it goes into the lungs through blood, it can even it can increase the blood flow to even diseased lungs, so that can make the oxygen level worse. But if you give a drug through inhaled route, it just goes to healthy lungs, so you can improve your oxygenation and actually won't make it worse. So that's the reason why the decision was to try the inhaled therapy. And as you can see, this is a short-term trial, 16 weeks, and I would like to get your attention to the red curve. Those are the patients that received inhaled treprostinil. And this is the y-axis here is the 6-minute walk distance. So the 6-minute walk distance improved in patients treated with inhaled therapy, whereas in placebo, it decreased. So when we combine these two, we call this as placebo-corrected effect. The benefit was ultimately 31 meters. And to your right-hand panel looks at various subgroups. And what we noticed is like the benefits of this drug was more in patients who have little advanced disease. So when your pulmonary hypertension is advanced, the benefits from the therapy was better. So this is indicated by this group here called the PVR. PVR is resistance in your lungs. If the resistance is more than 4 Wood units, the benefits were better. And also it was dose dependent. This is very interesting. In the bottom, if you see, this is the number of breaths the patient took. More the breath they took, the better the benefit was. So this was a convincing study. They not only they looked at the 6-minute walk distance, they looked at something called NT-proBNP. This is a blood test we do to see how happy your heart is. Lower the number, happy your heart, meaning right side of your heart. And as you can see here at baseline before treatment, this is the inhaled treprostinil group, and this is the placebo group. The number was same. Whereas as the treatment progressed at 8 weeks and 16 weeks, with inhaled treprostinil, the 550 number got down to 485 and then down to 454. It came down, which is good. Lower is better. But whereas patients treated with placebo, this number went up. So the heart was more happier when it would receive the inhaled treprostinil drugs. And also, when they looked at clinical worsening, like patients did much better. They stayed out of the hospital, they lived longer, and there was less progression of this interstitial lung disease when they treated with inhaled treprostinil. So based on this, FDA has approved this drug for treatment of pulmonary hypertension due to interstitial lung disease. So this is the first therapy that's available for these patients. We are very fortunate to be part of this trial. So we also participated in something called an open label extension study. This is not yet published, but it has been presented in different meetings. So basically in an open label extension study, the patients who participated in the trial get the drug and we follow them for a longer time. So in the top graph here, you can see these are the two arms which received either placebo or treatment initially up to 16 weeks. But after 16 weeks, both groups then went on the real drug. And then patients were followed up to 1 year, 52 weeks. And you can see here, this is the 6-minute walk distance. The green line is your initial patients who received treatment. And when they were continued for another year, the benefits persisted. So they started close to 250 meters, they benefited up to 280, and they remained at 280 even at 52 weeks. The placebo group on the other side, there was an improvement in 6-minute walk distance after they were switched to the real drug, but it was not as good as the initial treatment group, suggesting that even a 16 weeks delay in treatment could have an effect, and patients are not able to catch up with those who received drugs early. Similarly, they looked at this NT-proBNP enzyme, and when they went on the open label trial, patients got better. For example, this is baseline, this is 8 weeks, and this is 16 weeks, but there was no significant difference with treprostinil arm. We can see the BNP decrease at 8 weeks, decrease at 16 weeks, and even at 52 weeks or 64 weeks, it continued to decrease or lower. In the placebo group, at 8 weeks, it was higher. 16 weeks, it went even higher, but when they went back on the drug, it decreased further. So it does benefit the heart, but like the 6-minute walk distance was not able to get better even after 16 weeks of delay. On the open label extension trial, the investigators also looked at whether the clinical worsening is better. As you can see, patients who received the placebo arm are on the black and the treatment arm are on the green. And the 16 weeks delay had an effect on their clinical worsening. Patients were never able to catch up as those who received initial treatment, suggesting that 16 weeks delay may have an effect and we need to treat them early. Their lung function test got better on the inhaled treprostinil therapy. So that's the inhaled treprostinil for PH due to interstitial lung disease. Now I'm going to talk about a different drug called Perfect, which is inhaled treprostinil, the same drug, but for pulmonary hypertension due to COPD or interstitial lung. COPD. This is the previous trial was pulmonary hypertension due to interstitial lung disease. This is pulmonary hypertension due to COPD. So this is also a randomized double-blind placebo-controlled trial. As I said, this is pulmonary hypertension due to COPD, not ILD. Interestingly, this study was terminated just last month early due to an unfavorable balance of benefit to risk and concerns about the anticipated time it'll take to complete the study enrollment to either refute or confirm these initial trends. So this is a learning lesson for all of us. You just cannot extrapolate data from one disease state to the other. For example, PH due to COPD and PH due to interstitial lung disease, both are in the same group, but each and every pathology is different. So the treatment is not going to be the same for each one. So this is an important message, I think, for all of us. With that, I'll now move on to something called chronic thromboembolic pulmonary hypertension, which is the pulmonary hypertension due to blood clots. As you all know, currently the best treatment for blood clot-induced pulmonary hypertension is a surgery called pulmonary thromboendarterectomy. But not everyone is a candidate for this surgery, either because the clots are too small and deep into the arteries, or patients have other comorbidities that they're not candidate. For those patients, we call them as inoperable CTEPH. Right now, the only approved therapy is riociguat, which is a medication. But more and more, we are gaining experience with a new percutaneous procedure called BPA, balloon pulmonary angioplasty. This is a procedure where it's done in the cath lab. It's done as an outpatient procedure. We go through the groin or through the neck. We take a catheter into the lung arteries. We blow up a balloon and open up the small blood vessels. So this trial was conducted in France. The investigators wanted to see whether in patients who are not a candidate for surgery, so those are called inoperable CTEPH, what is the difference? Do they get better with BPA or do they get better with riociguat? And this is a 26 weeks trial, and this is the data on the 6-minute walk distance. You can see patients who got BPA in blue, their 6-minute walk distance got better than those who got riociguat. And the data to your right is the pulmonary vascular resistance, how much the percentage of pulmonary vascular resistance drop. And you can see with the people who got the balloon, the drop in pulmonary vascular resistance was significantly higher, close to almost like a drop to like 55%, whereas in riociguat, it was like close to 25%. But the balloon procedure was not without risk. There was more benefit, but there was increased risk. You can see SAE means serious adverse events related to BPA was 42% in patients who received BPA, whereas in medicine, it's only 9%. So it's an invasive procedure. There is a risk associated with it, but the benefits were better. What interestingly these investigators did was in a subgroup of people who first got the drug, eventually they went on to get balloon again. So there are people who just got balloon, and there are people who got medicine and then moved on to get a balloon. And in those who got balloon after taking the medication, their adverse events were significantly much lower. So although this group got balloon, they got it after medicine, their complication rate is only 14% compared to 42%. So the message from this trial is maybe it's a combination of therapy that's helpful, medicine plus balloon. First give medicine, lower the pressure, and then do the procedure so that the complication rate is lower. And again, I just want to make sure this is only for those who are inoperable. If somebody is operable and candidate for surgery, they should go for a PTE. Finally, I'll move on to pulmonary hypertension due to left heart disease. There are several trials that have tried the current therapies that are approved for pulmonary arterial hypertension in patients with pulmonary hypertension due to left heart disease. But all these trials are either neutral or some are even negative, suggesting that these therapies are potentially harmful. There's a consistent message that these drugs increase heart failure, they increase death, or they increase hospitalization. But there are there's one drug that's approved to treat heart failure recently that has shown to be significantly beneficial in this patient. So these are called SGLT2 inhibitors. And these are drugs that have shown to improve cardiovascular outcomes in patients with heart failure, meaning they reduce cardiovascular mortality. There are two drugs, dapagliflozin and empagliflozin, 4 big randomized trials. And randomized trials means we are talking about thousands of patients, 4,000 patients in this trial, 3,000 patients in this trial, 6,000 patients in this trial. In all 4 trials, consistently, there was a 25% reduction in cardiovascular death or hospitalization for heart failure. So it's a very strong message. Based on this, the FDA has now approved these drugs to treat heart failure, both types, reduced ejection fraction, preserved ejection fraction. And heart failure is the most common cause for pulmonary hypertension due to left heart disease. So this is a good news for patients with pulmonary hypertension due to left heart disease. So not only in summary, these drugs improve exercise capacity, reduce all-cause mortality, they reduce heart failure hospitalization. There's also some early animal data or experimental data suggesting that these drugs do work in animal models of pulmonary hypertension due to HFpEF. This is a rat model where the rat is obese and receives a compound and gets pulmonary hypertension. And when you treat those rats with this drug, the pulmonary hypertension gets better. Then the last one I will talk about, there's a new drug called levosimendan. This is a drug that's approved in the Europe, that's not available in the US. It's used to increase the contractility of the heart in patients with weak heart, used in patients who undergo cardiac surgery. And this drug is now tested in a very small clinical trial of 36 patients with pulmonary hypertension due to a specific type of left heart disease called heart failure with preserved ejection fraction. And we were part of this trial, and what we saw was their patients' exercise capacity got better. The 6-minute walk distance, you can see people in blue are the ones who received placebo, and people in the red are those who received this drug. And at 6 weeks, there was an improvement in 6-minute walk distance. This is a little complicated drug. It has to be given IV. It has to be given once a week. So all patients got something called a catheter, and a home infusion nurse would go in and infuse the drug once a week for 6 weeks. Fortunately, now this molecule is available as an oral drug. So we and others have transitioned these patients from IV to oral, and they're being followed on an open label phase. And they're still doing reasonably well on the oral therapy. And the company is planning to do this drug as a phase 3 trial on the oral version next year. So hopefully this will transpire for our patients. This drug was reasonably safe. We did not see any side effects significantly in patients who received this drug compared to placebo. And with that, I will, similar to Dr. Ventitulo, we want to convey our sincere gratitude to the patient volunteers, caregivers, research staff, the sponsors, and an organization like Pulmonary Hypertension Association for supporting research, without which, we can't advance our knowledge and treatment for our patients. And I'll stop there, and thank you for the opportunity.
Thanks very much, Dr. Thinoven. That was wonderful. Just a couple of very quick questions. One from one of our attendees asking if there have been comparative effectiveness studies of Tyvaso using a breathing machine versus a DPI for ILD.
Okay, so I'm not able to see you guys. Okay. Yes, so there is DPI is a dry powder inhaler. Tyvaso is a bulky and nebulizer. So it's a specific nebulizer for inhaled treprostinil. It's difficult to carry. And now there is a DPI that has been approved to use inhaled treprostinil. There's no randomized control trial on that, but the company did an efficacy trial, and the drug delivery was similar. So based on this, FDA has approved it, and we are starting to use it for patients. There are some practical difficulties. Tyvaso would be covered under Medicare, I think Part B as hospital thing, but DPI is covered under Medicare Part D. So some insurance may or may not cover, or the copay could be high. So that's the limiting issue. The second issue is, to use DPI, the patients have to take a deep breath. So if they have rapid, shallow breathing, they may not be able to use it. So we do a little test at bedside and see whether they can take a deep breath. If they can do it, then DPI would be a good option.
There have been some really great questions in the Q&A and the chat, and I would just encourage the audience to continue posting any questions they might have there. One that I think is really relevant to this conversation about new therapies, particularly in the space of PAH, is how do we advance the right treatment for the right patient approach, and what does that look like moving forward? Do you have any thoughts on that, Dr. Ventitulo?
Well, I think the work that you all have done in PVDomics is going to go away towards that. So Dr. Hemnes and others have just completed a really large-scale effort to sort of go beyond the clinical classification of pulmonary vascular disease and to look at some of the common molecular and genetic targets. And I think once we understand more about patients with pulmonary hypertension, not just group 1, but all groups, and some of the pathways involved in causing disease, or more severe disease in some compared to others, even with more common problems like left heart and lung disease, for example, we'll be able to start to tailor therapies. I also am hopeful that as we start to understand more about which subgroups of patients may respond to which a given group of therapies, we may get smarter in our trial design, so that upfront we start approaching patients who are most likely to see a benefit, and sort of these are called adaptive trials. We can organize our trials in such a way that we're just smarter and more efficient in our approach.
What are your thoughts on this, Dr. Thanapan?
Yeah, great. Oh, so on the, I was reading the other question, Anna, sorry.
Okay.
No, I think exactly like as Corey really nicely summarized it. So I think that's the future. The Triton trial, which looked at 3 drugs versus 2 drugs, is very fascinating. And there are some messages there. As you know, there is a small patient, 16 or 21 patient trial from France, where they gave all 3 drugs, and there was almost like 99% 5-year survival. And is it all 3 drugs adding together and working together, or there are some patients who just specifically respond to 1 drug, and we are just, by giving all 3, we are just, we're treating those pathways. So I think that individualizing therapy would be phenomenal if we can, smart scientists like you all should be able to do it in the next several years.
And along those lines, if I may put you on the spot for a moment, one of the pre-submitted questions was about nitric oxide, so-called vasodilator responsive individuals, and whether there are advances in identifying who might be best responsive to those drugs, and whether the science is advanced there.
Yeah, so we were interested in this years ago. There are some people with idiopathic PH, and by some I mean a small percentage, like 5 to 10% of people with idiopathic PH have a marked reduction in their pulmonary artery pressure when they inhale a drug called nitric oxide at the time of right heart catheterization. And these people can be treated with calcium channel blockers that are not FDA approved for this indication, and not really the other standard therapies that we use, as long as they meet these very specific criteria. And we used these folks because they have a markedly improved survival compared to the other kinds of pulmonary arterial hypertension, as sort of a proof of concept that they may have a different blood signature of RNAs, which are sort of markers that you can see in the blood. And we were able to see that they were markedly different in their blood patterns compared to other forms of PAH. And the science really hasn't moved a whole lot past there, but it just has been a proof of concept that you can identify these sort of subgroups of PAH that may be responsive to drugs. We're presently working on trying to do the same thing with people, trying to predict if they could use prostacyclins to treat PAH and figure out which patients are most likely to derive a benefit from that. But that we haven't completed yet and haven't published yet. So I think there are some moves in the field to do that with drugs that are more commonly used than nitric oxide or calcium channel blockers.
Maybe I'll take the question on the exercise-induced pulmonary hypertension. There's a question on exercise-induced pulmonary hypertension. Is there any treatment, history of recovered cardiomyopathy with preserved EF? So the short answer is there is no drug to treat exercise-induced pulmonary hypertension at this time and point. The answer to the second question is there a treatment for recovered cardiomyopathy with preserved EF? The sodium glucose cotransport receptor inhibitors, or SGLT2 inhibitors, are approved to treat heart failure with preserved ejection fraction. There's recent data suggesting that even in patients who had a low EF before and who have recovered now, those people still benefit from SGLT2 inhibitors. There was just an article published this past week. Is on an average, your survival goes up by 2 to 2.5 years when you take those drugs. So it's not subtle. It's a cardiovascular survival goes up by 2 to 2.5 years even in those patients.
And we had a question, which if Corey, if you're willing, I wouldn't mind having your comments. Former breast cancer patient and PAH group 1 patient who had to stop an anastrozole due to side effects. Any other medications which could be used for the same hormonal outcomes? Do you test hormone levels in those individuals? And what are the implications for that history based on the sex hormone paradigm in PAH?
I would say, first of all, congratulations on being a breast cancer survivor. And secondly, I think, while the hormone hypothesis of PAH is certainly interesting, and we're studying this now formally in trials, it's too early to say that any of these treatments are effective. And so the approach should really be to be on, potentially a preventative therapy for a secondary preventative therapy for breast cancer, and have a discussion with your pH provider about their thoughts on if this could potentially impact their pH. But in my clinical practice, even though I do this in research all the time, I don't measure hormones, and the therapies that I discussed are not yet approved, and so they're certainly not yet ready for clinical treatment. We should know a lot more, even if these trials, if these therapies don't work. I think we're going to learn a ton more about the hormone sort of background in pulmonary arterial hypertension, and sort of combine this going forward with a multimodal approach. The one thing I'll just say that, the one area where we do sort of make recommendations is in premenopausal women. We, of course, encourage them to take precautions about pregnancy avoidance, but we often do that in a way that does not involve additional exposures to estrogen because of the thrombotic or blood clot risk, as well as this sort of feeling that estrogen may drive pulmonary hypertension.
One question that I think is important to answer in the Q&A has to do with sotatercept, and so sotatercept targets the BMPR2 pathway and sort of rebalances it, if you will. And we know BMPR2 mutations are associated with heritable PAH. So the question is, are there specific data about heritable PAH within the sotatercept trial? And would that drug be relevant to all kinds of PAH, even folks who don't have a mutation? I can give you my thoughts if you want, but you can go.
Yeah, maybe I'll start and then you can add to it. I think if I understand right, we were part of the STELLAR trial, and it's for all comers, so it's not for heritable PAH alone, but people with heritable PAH can participate. I don't think there's any data based on the trial whether it's beneficial in heritable PAH alone. I don't know. Second question is it useful for everyone? I think it's useful for everyone. The BMPR2 pathway has been implicated even in patients who don't have the mutation. So the drug is effective even in patients who are non-heritable.
I think that's just how I would answer it myself. The trial did not enroll exclusively heritable PAH patients. And so I anticipate that the drug, after I read the paper and FDA reviews the data, would not get FDA approval exclusively in that population. It'll probably be all forms of PAH that were included in the trial as performed.
Maybe I'll ask the question for you all. One of the big buzz about the sotatercept is the reverse remodeling. I'm just curious to get your thoughts on the reverse remodeling role of this drug.
I'm happy to wax eloquent on that one because I like to think about it. I think we don't know as a community what reverse remodeling is because we don't have access, unfortunately, to lung tissue. We don't biopsy people who have PAH because we're afraid that will cause bleeding or harm or something like that. And that's really the only way to know in humans that you've reverse remodeled or essentially taken all those lesions that plug up the pulmonary vessels and made them go away. If you don't have pathology, you don't really know that you did. So we try to triangulate at that. We try to use a heart catheterization. We try to look at heart function. We try to look at exercise tolerance. It's possible that the drugs that we're using now reverse remodel, although we don't think that they do. We just don't know. And the same, I don't think we're going to know that information with any of the drugs that we've discussed today. So I think the only way to know that you've reverse remodeled somebody in our current paradigm, like with what tools we have available to us right now, or if they live for a whole lot longer and they feel like a normal person. I can't think of anything else. I don't know what your all thoughts are on that.
Yeah, I think I totally agree, Anna. I think there's a lot of interest in developing novel imaging tools to get at this question. But I have to be honest, maybe I'm too simple. If my patient feels better, functions better, and survives longer, I think I'm satisfied. I think we don't really have quite a good handle on how our currently approved therapies work. There could be systemic muscle effects, direct RV effects, and in a way, as long as the outcome is good for patients, I think that, in my mind, should be the focus, even though mechanistically interesting to think about.
Maybe, Corey, I can just close with a quick question. I know we're right at the hour, but there have been a little bit of a common thread throughout the Q&A about individuals with connective tissue diseases and whether they've been included in the PAH trials that you described and whether there are specific therapies.
Yeah, I saw a couple of them, and so I actually took the slides out just in the interest of time. There was one question specific to rituximab. There was an interesting NIH-funded phase 2 trial of rituximab in scleroderma-associated pulmonary hypertension. It was a trial that was difficult to enroll, and so there were some changes over the course of the trial. While they didn't, hit the positive trial sort of criteria, there were a number of secondary messages in the trial which I think were promising. So, personally, when I have patients with connective tissue disease that have other indications for immunomodulation, I try to advocate for rituximab in my patients, although that might be controversial and the panelists may disagree with me. I would make the comment that, in all of our trials, connective tissue disease is usually the second most common indication. And while our connective tissue disease patients certainly face a number of other challenges with systemic manifestations, they respond well to PAH therapy. So I try to, at the bedside, sort of encourage my patients that while they have some other issues to deal with, their esophagus, their Raynaud's, for example, they're just as likely to respond to PAH therapies as if they didn't have their connective tissue disease.
Well, I think that was a really great conversation. Thanks for joining us.
I am back. Thank you so much to everyone. Can y'all hear me? Okay, perfect. Thank you so much, Corey, Evan, Thanapan, and Anna, for joining us today. There was a lot of information shared here, and I could just tell from the comments in the chat and the questions that there were, people really got a lot out of what you all presented. So thank you again. And thank you to Brown, Vanderbilt, and University of Minnesota for allowing you to be here today to speak to us and share this information. We appreciate that. And I appreciate y'all sticking through with the technical difficulties in the beginning. Again, I would also like to say thanks to our sponsors, and I'm just going to quickly go through this because I realize this is probably where y'all didn't see. Thanks again to our sponsor, Janssen Pharmaceuticals, for its diamond level sponsorship. And lastly, I would like to say, as a nonprofit membership organization, PHA relies upon the support of its members and global network of healthcare professionals, early career investigators, and PH patients and caregivers. So if you are not a member, we ask that you seriously consider joining PHA. If you are already a member, thank you so much. If you're not, please feel free to sign up for a professional or patient membership. Right now, we are offering a special 20% discount for professional memberships. You would use the code PRO2022 to join and get that discount. So thank you again to our presenters today. Thank you to the audience for tuning in and asking those great questions. We appreciate you, and we hope you have a great holiday season and a wonderful new year. We'll see you in 2023. Bye, everyone.